All right, hi everyone. I just advanced like usual.
Yep.
Okay, sorry, that was my little housekeeping item. Thank you all for coming, and thanks for that great introduction and the invitation. And I want to talk a little bit about screening for colorectal cancer. And how it affects you, and we'll sort of start at the beginning and go to the end, and hopefully you'll know more when we're finished than you did when we started. So I'd like to start with some statistics just so that we understand the scope of the problem we're looking at. Colorectal cancer is the fourth most common cancer diagnosed in the United States, which is a large number. There were 146,000 new cases of colon and rectal cancer diagnosed in 2019, 51,000 deaths that same year, and 4.2% of all people will be diagnosed with colon cancer in their lifetime. These are the trends. I'm going to follow some bad news with some good news, right? Since 1992, our death rate from colorectal cancer has been steadily declining. The case rate is on the top, the square boxes in the light green color, the death rate is at the bottom. And this decline is pretty much completely attributable to the screening that we do, that we were not doing at least as vigorously in 1992 as we are now. A little review of anatomy or presentation of anatomy. If you've never sort of thought about how your colon works, starting sort of at the bottom left side as you face it, right? This person who belongs to this cartoon colon is facing us. So you see on the far left side of the screen the word right, and the far right side of the screen it says left, right? That's because that is that person's right and left, and that person is facing us. So the colon, as part of the digestive system, all runs in one direction, right? Goes through and out. And the beginning part of the colon is down there where you see on the lower left, which is the right side of the person, at the cecum. And if you see that little appendage that's sticking off toward the center, that is the terminal, what we call the terminal ileum, which is the very end of the small intestine, which is all sort of curled up, twists and turns would be in the center of this picture. So we don't look for cancer in the small intestine, but we do in a usual colonoscopy go into that last little piece there, which is called the terminal ileum. Then the very beginning of the colon is the cecum. The appendix, if you still have one, is kind of hanging off the cecum. And then going in the direction that the colon goes is the ascending colon. And then you get to the first turn, which is the hepatic flexure, so named because the liver is over there in the same neighborhood. And then you go across the transverse colon, and then it makes another turn through the splenic flexure, same thing. The spleen is right up in that neighborhood, that's why it's called that. And then down through the descending colon. The last little bit of the colon is called the sigmoid colon because it in real life has a little bit more of an S shape. And then into the rectum, which is that very last part. The rectum is kind of a vault where stool sits waiting to come out. Now you'll notice, those of you who are paying close attention, that I did not include the anus, which is the end part of the rectum and the part that's also visible from the outside. And it is a concern for anal cancer. And I want you all to be clear that when we do a colonoscopy, we're screening for colon cancer and rectal cancer but not anal cancer. That's a different procedure and a different lecture, by the way. So that I encourage you all to also pay attention to anal cancer screening and the anal cancer screening program, which is a different lecture in this same series usually. So it's helpful also to know a little bit more about colon cancer than just the statistics. And like all cancers, colon cancer grows from early stages to late stages. And also, like all cancers, we don't typically have any symptoms until we're in late stages. We also have fewer options for treatment and worse outcomes as the stages progress. So the whole idea is to catch things at the earlier stage. But you can see on the left-hand side, stage 0 is a cancer that's sitting on top of the, in this case, the mucosa, or the basically the lining of the colon. Then as it starts to invade the lining, you're at stage 1. Stage 2 is when you're starting to penetrate into the blood vessels, right? And those green things are lymph vessels, and the white things are lymph nodes. And by stage 3, you can see little dots in the lymph node. That means the cancer has already progressed to the lymph node. And then at stage 4 with the blue arrow, that signifies that the cancer has already started to spread to other parts of the body. We also have a different stage, just in case you hear these terms thrown about, right? So that they're stages, they're also what are called SEER stages. And you'll see what SEER means at the bottom, right? It's an acronym. So at the very beginning, you've got localized, right? So no signs that the cancer has spread. And then we go to something called regional, which means that the cancer has spread, but only to nearby structures. And then distant is when the spread has gone to farther parts of the body, not just nearby structures, right? So when you saw the spread here to the lymph nodes at stage 3, those are nearby, right? Stage 4 is when it's gone off to a frequent place. Next stop for colon cancer is the liver, and so forth. Okay, so you might see colon cancer staged by colon cancer stages, the 0 to 4 that you saw on the previous slide, or you may see a SEER stage, which is local, regional, or distant, or often you'll see both. But you can see that these are 5-year survival rates. So somebody is diagnosed with colon cancer. What's the likelihood that they will still be alive in 5 years? And if you're at SEER stage 1 or localized spread, you've got a 90% chance of still being alive in 5 years. If it's regional spread, that goes down to 71%. And look though, if it's distant spread, you've got a very high likelihood, 86% chance, that you will not see survival at 8 years after your diagnosis, right? Now, everybody knows the story of an outlier, someone who was diagnosed at a late stage and survived, or somebody who was diagnosed at an early stage and didn't survive. But the point is that those are outliers. That's not most people. This is looking at most people. So we'll get back to all of that in just a second, but that's when someone already has colon cancer, those last 3 points that I made, okay? So what is the risk of colon cancer? We're all sitting here tonight and we're all thinking about what's my risk of colon cancer, because as far as we all know, we don't have colon cancer, as far as we all know. So colon cancer risk is basically uniform across all adults age 45 and older, right? And what does that mean? That means that 90% of cases of colon cancer are concentrated in adults age 45 and over. this is what makes screening work, the fact that you've got a concentration of cases in a particular age group. This is why we don't screen 20-year-olds for colon cancer, because it's very unlikely that they will have it. You may notice the age 45, and you have this idea that is not an inaccurate one, that isn't that 50? What, didn't I start at 50? You probably did. I don't know the ages of everybody who's here tonight, but the recommendation went from age 50 to age 45 just a little over a year ago. So not all places where guidelines are published have even changed now, but this is as a result of seeing increased rates, particularly of rectal cancer among adults ages 45 to 50. So the American Cancer, there are different groups that have recommendations for screening. The American Cancer Society was the first to change the recommendation to age 45, but now all the bodies that that review data and make recommendations have changed their guidelines to 45. So that's average risk, right? Just being an adult over the age of 45. Who's at high risk, right? So that's increased risk of colon cancer in that adult age group. That's anyone with a family or personal history of colon cancer or polyps. So a family history means a family member, a personal history means you yourself, right? So if you have a history of having had colon cancer, then your risk of having it again is higher, is what that means. But also if you had a colonoscopy and a polyp was found, then you also have a higher risk to develop colon cancer compared to someone who has not had a polyp, right? There are certain diseases that put people at higher risk for colon cancer. Inflammatory bowel disease, which is Crohn's disease or ulcerative colitis, Lynch syndrome, which is a genetic predisposition, and there are some others, right? These are relatively rare, and most of the time people who have these risk factors know about it. And then there are also lifestyle factors that put you at higher risk for colon cancer. What do I mean by that? People who are overweight, people who are sedentary, people who smoke. So we'll get into a little bit more what we do about that in a second. Your risk of colon cancer increases with age, right? So the older you get, the higher the risk. And that notwithstanding that, the most recent increases in the population have been observed in the younger 45 to 50 age group. What is screening, right? I always like to go to basics because we're throwing words around and maybe not everybody knows what we mean, right? So if you come to our office saying, I've got some bleeding, or there's been a change in my bowel pattern, or I've got this ache or pain or nausea or whatever, that's not screening. That is trying to diagnose a problem, right? And as part of that process, we might recommend that you undergo a colonoscopy depending on what the problem is, right? And we might recommend that despite your age, and we might recommend that despite whenever you last had a colonoscopy for screening purposes. Screening means that you are looking for something before you have any symptoms, right? So think about it. Women at a certain age are recommended to undergo breast cancer screening, and that includes a mammogram. And the whole point of doing that mammogram is because there might be a problem and no one would ever know unless we went looking, right? So this is the same thing we mean by screening for colon cancer. We're going to go looking for colon cancer before we see any signs or symptoms that there's a problem. And we do that because screening increases the chance that if you find the cancer, it will be in the early stages, right? If you wait until you have a problem, chances are you're going to be farther along on that spectrum that I showed you before, which means that there will be less and less that we can do about it, and more likely that your outcome will not be good, right? As you progress from the 90% survival rate to the 14% survival rate. We'd obviously love to intervene when the number is closer to 90 rather than closer to 14, right? So colon cancer is easier to screen for compared to some other cancers, right? There's all kinds of cancers, and there are lots of them that we don't screen for just because screening doesn't work in those cancers, right? But in colon cancer, it does work because we have this age group where the risk is higher. So that's what we would refer to as our target population, right? If we had to screen everybody for colon cancer, that would be more, we have trouble keeping up with the number of colonoscopies we need to do now. Could you imagine if we had to start at age 14 or 15 or even younger, right? So that wouldn't work as a screening methodology, but because we've got most colon cancer concentrated in one part of the population, we know who we have to target in terms of screening. The other really sort of interesting thing about cancer is there are these precancerous polyps. So these are growths, we're going to get into this more later, but we actually have the ability to prevent colon cancer by removing these polyps before they have the chance to turn into cancer. And the other big advantage with colon cancer compared to other cancers is it tends to progress very slowly. So if we find a precancerous polyp now, it might take 5, it might take 10 years before that turns into a colon cancer. So otherwise, I mean, if it could happen at any time, we'd maybe have to be doing colonoscopies every month, right? Well, that's obviously not doable. So since they progress slowly and we can wait 5 to 10 years in most cases for the next colonoscopy, that makes it feasible in terms of an approach to screening. So what are polyps? Polyps are small. Well, they're actually small by anyone's standards. I think, I'm thinking in my head right now, they're not all small, but a large polyp is about 1 centimeter. And those are very rare to find. 1 centimeter is a little smaller than 1/2 inch. And most people in the world would think of 1/2 inch as still being relatively small. But we don't often find polyps much bigger than that. And most of the time, they're somewhere between 2 and 5 millimeters, which is 5 millimeters is 1/2 of a centimeter. So that's a little less than 1/4 of an inch. So they're all small, right? And these are growths that you can see on a colonoscopy, providing the colon is clean enough. But they might look like little bumps, or sometimes they're mushroom shaped. So they've got a little bit of a stalk and then a larger head on them. And by age 60, you have about a 25% chance of having at least one polyp, right? So 1 in 4 people at the age of 60 will have developed at least one polyp. Most of the time when we do a colonoscopy, if we find polyps, they're somewhere between 1 and 5 of them, but sometimes there are a lot more. That's a rarer finding, but in those cases, we change the follow-up based on what the findings are. What are the different types of polyps? There are different types of polyps. Some of them are completely benign, which means if you were to leave them there and sit and not worry about them, nothing would happen. They would stay there. They might get a little bit bigger, they might not, but they're not going to turn into cancer. Then there are polyps that are not cancerous now, but could turn into cancer over time. Those are sometimes referred to as precancerous polyps, and that growth from benign to cancerous goes, as I said before, slowly in most cases. Here's the interesting part, though. You can't really tell the difference between a benign polyp and a precancerous polyp just by looking at it. You need to take it out and send it to the lab and have it analyzed, and then you know what kind of polyp you're looking at. So this is a little bit of a guide as to how polyps progress, right? Starting from the left, you've got just a hyperproliferation, right, or an adenomatous small polyp. Sometimes they're still, and you see the line at the very bottom, as we progress to the right, they go from being benign to being malignant or cancerous, right? So most of the polyps that we find on colonoscopy are one of those three that you see to the left. Then you go into severe dysplasia, right? So it's a precancerous polyp that has begun to turn into cancerous tissue. For those of you who don't know, all the cells in the body reproduce according to a very specific plan, and different cells do different things. And when you have the need to regenerate cells in different parts of the body, your body knows which kind of cells go where. That's under normal circumstances. Cancer cells are cells that are generating in places where they don't belong, and they don't necessarily know when to stop. And so you get this over-generation of cells that eventually becomes dangerous because it goes around to different parts of the body, and it saps energy and causes blockages and pain and all kinds of different problems. Cancers of different kinds are prominent enough in our society that we probably all know someone who has had cancer and gone through different stages of either treatment or progression of cancer. And it's not anything you want to do. It's a terrible disease, which is why we like to prevent it when we can. So as you see on the right, the malignant cancers, the cancer cells shown in white, right, are invading into the lymph node tissue below the basement membrane, right? And then you see it just kind of invading into the colon itself on the right-hand side. But so how do we screen for colon cancer? Good question. We have lots of different methods of screening for colon cancer, and I've divided them into tests, visual tests. So these are exams that are done, but they're done, of course, we're looking at the inside of the body. So there's two different ways to do that. And then there are stool tests, which is where we analyze stool and, pardon me, come up with different results that would point us in the direction of colon cancer if it's brewing. So let's start with the visual tests, and the one that most people are familiar with is colonoscopy. And colonoscopy is a way of examining the inside of the colon with a scope. You see the top picture on the right-hand side is a picture of a colonoscope. It's operated by a person who has been trained how to do this exam, and that's usually a gastroenterologist. And you see at the very tip there, I just wanted to point that out, it's got a little sort of curled around at the end, at the very end there in the center. The colonoscope is from the operative end, one is able to change the direction and navigate that colon that I showed you in the beginning part of the talk around the corners and through the little valleys of the colon to get to the end, and even look back on itself, as you see in this picture with the tip of the colonoscopy, the colonoscope rather, turned back on itself. There's also a light there. Obviously, it's dark inside, and there's an operative end that can pluck off the polyps, suck them up through the tube, and then they go to the lab. Remember, I said we need the polyps to go to the lab in order to know what they are. There's also a little water, can be just, you know, if you've got a little stool left after your colon prep, that you can rinse out the colon and suck up that little, you know, basically do a little bit of a cleanup. We can't do a whole prep that way, but if there's little spots that need to be seen better, we can do that way. So it's actually quite an amazing device. It does all those different things. And that's why when you do a colonoscopy as your colon cancer screening, oftentimes you're kind of one and done. So we'll get into that a little bit more when we talk in a second about the risks and the benefits, right? CT colonography is a way of using a CT scanner to take a picture of the colon. And this is the advantage of this approach is that you get a good picture of the whole colon and you don't need anesthesia, right? So colonoscopy, very, very, very few people request that it be done without anesthesia or sedation of some kind, because it's uncomfortable to have this thing all the way up inside your body like that. Can be done, but most people don't want it to be done that way. A CT colonography doesn't require anesthesia, and it gives us a very good picture. The problem is if there's a polyp there, we can't do anything about it. Then you still need a colonoscopy after that. But some people are at high risk for anesthesia. Either they have a heart condition or a lung condition, and or they, for one reason or another, the colonoscopy didn't work out. Because you need to be prepped for a colonography, we sometimes wheel those people quickly over to radiology to get a colonography as a next best test. Again, we'll get into that in a second. Different kinds of stool tests. There's something called, I didn't include everything here, just examples, but there's something called a fecal immunochemical test. That's that box in the middle on the right-hand side. Tends to be a little bit of a test tube. It looks probably familiar to most of us by now. We've done a COVID screening test that's got one of those devices that you drop a couple of drops of solution in, and it delivers you a couple of lines, one line or two, depending on the result. The one that most people have heard of by now is something called Cologuard. And this is a stool test that is done in a kit, also done at home. So you don't need to prep and you don't need to undergo anesthesia. You prepare a stool sample, send it back to the lab in the box it came in, all in the privacy of your own home. There are a couple of different tests that are no longer recommended. We used to do a flexible sigmoidoscopy, so very similar to a colonoscopy, except it's just that last part of the colon, the sigmoid colon. In earlier days, we thought that that was where most of colon cancer occurred, and so we did those. Those are, it's possible to do those without anesthesia and in an office, and instead of a full colon prep, all you need are a couple of enemas for that. So it's much easier to prepare for. And then a fecal occult blood test. Those are probably a lot of you are familiar with those too. Requires a rectal exam with a finger, and then you wipe a couple of times on a card and add developer, and it tells you if there's any blood in the stool. So flexible sigmoidoscopy is no longer recommended just because a lot of colon cancer happens in other parts of the colon. So just because there's none in the sigmoid colon doesn't mean there's no cancer anywhere else. The fecal occult blood test is no longer recommended because blood can be for a whole bunch of different reasons. A lot of people have hemorrhoids, and that can turn a fecal occult test positive. That would not mean that you had colon cancer, it just mean that you have some blood. It also is possible that early colon cancers, the vast majority of them don't have any blood coming from them, so that would give you a fecal occult blood test that's negative, even though there is colon cancer brewing in that patient. So these are no longer thought to be accurate, and frankly, we have better tests now. When this was developed, it was all we had. So let's look at the advantages and the disadvantages of each of these approaches, right? So colonoscopy, I said some of these before, but I'll sort of review and go through them again. The advantages of a colonoscopy is you get to see the entire colon. You can do biopsies and remove polyps all at the same time. Occasionally, we diagnose some other condition at the same time that we're doing a colonoscopy to screen for colon cancer. And best of all, if you're at average risk and if the colonoscopy is negative, you don't need another one for 10 years. The disadvantages are that clean out that you have to do the day before, which everybody hates. We have some newer approaches to the prep, the colon prep, that are not as bad as the old one, but still no fun for anybody. On a colonoscopy, you could miss very small polyps. They're relatively high cost in terms of approaches to, all of this is cost effective, by the way, in terms of preventing colon cancer. But when you compare screening methods, colonoscopy is the most expensive. And that makes sense. You have to do all that prep. You have to take the day off of work, maybe 2. You need anesthesia, so that often includes an anesthesiologist. You've got a gastroenterologist, you've got the place where it's done. All the costs together are the highest cost way of doing colon cancer screening. And there is a small chance for complications, just like with any procedure. There can be infections, other kinds of procedure complications or anesthesia complications that you don't have if you do with other approaches to colon cancer screening. So a FIT test, as they're often called, the fecal immunochemical test, this is, sorry about the typo there, this is what you saw with the test tube. Advantages are they're inexpensive, you don't need any prep, you don't have any particular risk to the colon since it uses stool that's already come out of you. And you do it at your convenience and the privacy of your own home. And so it does not require you to take days off of work or to have anesthesia or to go through the big onerous colon prep. Disadvantages are this may miss polyps and some small cancers. There is a possibility of a false positive, which means it thinks there might be colon cancer, but there's not, in which case you would get a colonoscopy that you didn't need, right? And so you may still need a colonoscopy. It's not a guarantee that you could avoid the colonoscopy. And in order for this to work as a screening method for cancer, you have to do it every year. There are places where this is the way the health systems usually, that this is their approach to screening. If you're at average risk, you don't get a colonoscopy, you get a FIT test, and you get someone in an office somewhere who's good at nagging you to get it done every year. And if you look at the aggregate results, they actually prevent more colon cancer and spend less money doing it than we do with all our colonoscopies. That's a health policy conversation, so we're not going to get into that here. But this is a very effective way of screening for colon cancer when it's done the way it's supposed to. The stool DNA test, this is the Cologuard test, right? Similar advantages, there's no direct risk to the colon because the stool is already outside. There's no prep, it's done at home. Oh, those are all the same. The disadvantages are similar, may miss some small polyps. It's done every 3 years. There's a possibility of a false positive, and you may still need the colonoscopy. And I do always tell my patients this, so I'm going to tell you this. Colon cancer screening, like all screening in the United States by law, is covered at 100%. So whatever procedure you decide to do first, right? If you come see me after your primary care provider has referred you for colon cancer screening, I'm going to have a conversation with you about, do you want to do colonoscopy? Do you want to do this? Do you want to do that? Whatever you're eligible for given your risk factors. And if you choose to do the Cologuard, it's going to be covered at 100% because insurance plans are required to cover them that way. If you need the colonoscopy after that, then that colonoscopy is not considered a screening procedure. It's the same procedure, but it's being done for a different reason. And so your insurance is going to bill that not as a screening procedure, but as a standard procedure. And so it's going to be subject to your plan deductibles and co-payments and all that stuff. And in some cases, that's a lot of money. So I always, I don't want people to get surprised by that, because often that's not disclosed at the front end. So for those people, colonoscopy has clear benefits because it's way lower cost to them personally, if it comes to that. CT colonography advantages are, again, no direct risk to the colon because you're not, it's non-invasive. It's from outside. You can see the entire colon. There's no sedation involved. And if it's negative, we recommend the next one in 5 years. The disadvantages are you still have to prep, just like you do for a colonoscopy. Again, you may miss small polyps. You notice that that's a risk, a disadvantage to all of them. False positive results are possible with a CT colonography, so sometimes we see something we're not sure what it is, right? Colonoscopy, CT scans involve radiation, so there's that risk of additional radiation. You may still need a colonoscopy, and the same insurance issue as the Colorectal test, right? If you choose to do this as your screening procedure. Not many people actually do, to be honest with you. Since the part that people mostly hate is the prep, and you still have to prep when you do a CT colonography. So everyone basically says, in my experience, if I'm going to have to prep, I might as well just go ahead and do the colonoscopy. By the way, I should add, when I say that you may still miss small polyps on a colonoscopy, that is true. If you look at the statistics, colonoscopies are done and polyps are missed. Some polyps are very hard to see because they're flat and they're small, but there are also colonoscopies that are done and the operator, the person who's doing the procedure, is not particularly careful. That does not apply to any of, I know all the gastroenterologists at Eisenhower personally. I actually at this point know all the gastroenterologists in the Coachella Valley personally, and I don't believe that this happens with any of them. But statistically, looking at all the aggregate data in the United States, that is sometimes, unfortunately, the case. And so you see that reflected in the data. And that's not data that I think you would see it in if we had data specific to our region. So I just want to reassure you about that. I think that the colonoscopy is done almost without exception around our parts down here in this part of the country are high quality exams. The only reason that you would miss a polyp in a situation where the operators being very careful is if the prep is not adequate, right? Because if there's a lot of stool in the colon, obviously it's going to obscure your view. And so that's why we try to see you ahead of time to make sure that the prep that we're prescribing is going to be adequate to clean out your colon based on whatever your particular health issues are. Some people just need a more intense colon prep than others. All right, so who should be screened? So this is an interesting question, right? Average risk adults between the ages of 45 and 75 should be screened. So that's basically anyone between the ages of 45 and 75 should be screened by any one of those methods that we just talked about. Their advantages and disadvantages being taken into account, and the method, choosing the method that's best for you. Average risk adults who are older than that, from age 76 to age 85, may benefit from screening, but may not. And they should have this conversation with their healthcare provider. And I have a lot of these conversations, right? So why would you do one age 76 to 85? Well, it depends on the colonoscopies that you've had before and what the results were. And it depends on your overall state of health. and it depends on how risky the procedure is for you. So I'll give you an example. We have patients who have had strokes because they've had blood clots, and they now take medication that makes their blood thinner to make the repeat stroke less likely. Those people have to stop those medications for sometimes 5, sometimes 7 days prior to the colonoscopy. So for 7 days, they're going to be at higher risk of stroke while we're waiting to do a colonoscopy, right? So is that risk of stroke worth going through another colonoscopy? Below age 75, almost always the answer is yes, but after age 76, not always, right? Because a stroke can be pretty devastating. And to take that risk just to see if maybe there's colon cancer is not always the right choice to make, right? We all know that as we get older, health problems tend to increase, especially chronic health problems. Complications from procedures also increase as we get older. So we have to take all this into account. If someone's bleeding profusely and we think a colonoscopy is going to help us fix that problem, that's a whole different story. We're taking a perfectly healthy person and putting them through a colonoscopy. We better be sure as we can be, that we're not going to hurt them, right? At least we should not make anything worse, right? For adults who are age 86 and higher, the risks of screening are thought to outweigh the benefits, and this is according to the data. Okay, sometimes this is a hard conversation sometimes to have with my patients, because they think, well, I'm healthy. Why, is Medicare just giving up on me? No, according to the data, it really is more harmful than to do it than not to do it. And that doesn't mean we couldn't still elect to do a colonoscopy, especially if there were some other problem going on. But generally speaking, you don't want to be screening for colon cancer past age 86. What is average risk? We'll go back to that. I think I said it all before, but just to reiterate, no history of colon cancer or polyps, no history of colon cancer or polyps in your family history. Actually, it really is a family history of colon cancer, and by family history, I mean first-degree relative. So that's a parent, sibling, or child. If it's a more distant relative, or if the relative has only had polyps, that doesn't necessarily put you at increased risk, the same way it would if you were the one with the polyps. No inflammatory bowel disease, that's ulcerative colitis and Crohn's disease, and no hereditary colon cancer syndrome such as Lynch syndrome. If you meet those criteria, you're at average risk. Otherwise, you're at higher risk, which still means you should screen, just by a different methodology. And by the way, all the alternatives to colonoscopy are not recommended for anyone who's at higher risk, right? So you should not do a Cologuard test if you've had polyps in the past. For example, you should also not do a Cologuard test if your mother or father was diagnosed with colon cancer. So higher risk, someone with a history of colon cancer or polyps, someone with a family member, particularly a first-degree relative with colon cancer, someone with inflammatory bowel disease, someone with one of these colon cancer syndromes listed there, someone who is overweight or obese. Alcohol or tobacco use can increase your risk, a sedentary lifestyle, and a poor diet. These all put you at higher risk, right? When we screen for higher risk, it depends on the risk factor though. So family history depends on how closely related they are to you, as I said, a first-degree relative, and how old they were when they were diagnosed. Modifiable risk factors such as tobacco, alcohol use, and inactivity, we don't necessarily screen you more intensely. What we do is say, Get up off the couch, stop smoking, and get moving, and that will reduce your risk for colon cancer, right? A little more detail on family history, right? A first-degree relative diagnosed before the age of 60, or 2 first-degree relatives at any age. You start screening 10 years before the age that the relative was at diagnosis, or at age 40, whichever is the earlier date, right? And then you repeat if 5 years, if it's negative. If it's positive, then it might be shorter than 5 years, but not more than 5 years. If your first-degree relative was diagnosed at or after age 60, then you start at age 40, and then repeat in 10 years if negative. And if it's not negative, then it's according to whatever the findings were. A lot of us are at the point where, and I try to say this to all my patients, you might not have a history of colon cancer in a family member now, but that might change, right? Somebody might be diagnosed with colon cancer. So that then might change your risk, and it's good to find out at that point. If you are older than 75, here's what we looked at, right? Have you been screened in the past? And if so, what were the results, right? If all your colonoscopies were negative, then you probably shouldn't have another. How is your general health? If your general health is good, you may want to do one, because then your chances of living long enough to develop colon cancer are higher, right? Because you've got a longer life expectancy. On the other hand, if your general health is good, you're much more likely not to have complications from a colonoscopy. Would you elect to undergo cancer treatment if colon cancer were found, right? So think about that. If you're facing down some screening and you say, I would not do colon surgery, end up with a colostomy, radiation treatment, chemotherapy, I would not do any of those things. If you're 77, 78, 80 years old, those are perfectly reasonable decisions to make. And if you've already made those decisions, then there's no point going looking for colon cancer, right? And undergoing that additional risk. But here's the other thing I always tell people, because we have a slightly older demographic, you may have noticed in this part of the country. Make sure your family members know your history, because it might affect them, right? So tell your family members about this, and let them know to start screening, especially at age 45. For more information, I recommend the CDC website, not just for colon cancer screening, but for all kinds of information. The American Cancer Society is a great resource for all kinds of cancers, including colon cancer. And the Mayo Clinic website has terrific information about all kinds of disease states, including colon cancer and colon cancer screening, as do other major health systems like Harvard and what are some of the others? You've probably seen them: University of Michigan, Stanford. They all have great information websites that are open to the public. And to us, I use them all the time. So where can you find me and my group? Well, not in that building, in that picture, unfortunately. We have all moved to the Eisenhower campus in Rancho Mirage in the Hirschberg building, Suite 101. We used to have a couple of us in downtown Palm Springs at South Palm Canyon, but we're, as of January 1st, all in this office. All the colonoscopies, procedures of different kind are done here, either at the hospital or nearby at the endoscopy center. And there's our phone number. And that's the end of the slides. So I'm happy to entertain any questions.